Thanks again for inviting me to speak today. What I want to cover is really around health population modeling in low and middle income countries and how this idea of digital twin could be applicable or to the type of work that I'm involved in. So I'll be starting by talking a bit about universal health coverage as a policy goal, since not everybody is deeply enmeshed in health policy in developing countries here, just to give an overview. The second thing I'll talk about is a bit about the Disease Control Priorities Project, where it's come from and where it's headed. An example of a sort of a digital twin analog called the Fair Choices tool that we're working on, and a bit of reflections on the methodological frontier for this sort of modeling work, which I think has some implications for digital twins in other areas or intersection, I should say, in terms of computation, in terms of applications. So just to rehash for those who don't know, in the current global health era and regime, there are countries have signed on to what are called the Sustainable Development Goals. There are 17 of them. They're applicable in all countries, and they're aspirations for global development. The third goal is on health. And one of the main health goals that all countries have signed on to is to achieve universal health coverage. And this achievement of universal health coverage includes the idea of financial risk protection, access to healthcare services, and a quality affordable healthcare, as well as medicines and vaccines for all. So this is obviously a very aspirational goal, that everybody in the world gets access to the services they need. And so some people ask, well, what exactly does UHC mean practically? And there's a consensus that it involves kind of three elements. The first is ensuring that everybody obtains access to the services they need. And need is sort of the second component. And then they access those services without suffering financial hardship when paying for them. And so basically UHC has three goals: improving access to healthcare, particularly among disadvantaged populations. So it's equity orientation. The second is improving health. And the third is providing financial protection. So making sure that people don't go into poverty because of the need to receive healthcare. And so the way we typically think about universal health coverage is sort of three dimensions. The first is the proportion of a country or local population that's covered by needed intervention. So this is sort of the all people goal. The idea being we should drive towards having 100% of the population covered by universal health coverage. The second is obtaining the services they need. So what proportion of all available health technologies and interventions are accessible to the population? So you can think about that as another axis. And then doing so without financial hardship. So the third domain is what percentage of healthcare is prepaid or not paid out of pocket, basically. And you can imagine this cube filling up as countries work towards the upper corner here. So you can think about UHC as a goal which countries are moving more and more towards by expanding access to healthcare, reducing out-of-pocket cost, and giving more and more services to the population. Now, there's a variant of universal health coverage that's called progressive universalism, which basically says that ethically, the right way to think about filling up this cube is to focus on full population coverage, okay, and prepayment for a set of services that starts out more modest and expands over time. So rather than focusing giving a lot of things to a few people, you give a few things to a lot of people, and ideally for free or for very low out-of-pocket cost. And so then the real question for countries, particularly that have resource constraints, is how do you figure out how far along this dimension you can move? What sorts of services can you afford to provide for the population? And this is where the idea of essential health benefits packages come from. The benefits packages are basically lists of priority health interventions that are covered under UHC. They're usually assumed to be publicly financed, including through social health insurance systems. And there are kind of two different ways that benefits packages work. There's explicit packages, which have clear criteria for inclusion, what services are available or not. They're ideally transparent. Some countries like Thailand have worked on this sort of system for a long time. And there's a sort of implicit package, which is basically an open-ended commitment to a group of people to provide them whatever they need. This is politically popular, but financially, you can't really deliver on this. And so our own country here in the US struggles from this, where essentially most people get what they need if they have insurance and if they have access. But promising everything to everyone doesn't always work when you have financial constraints. And so the question for poor countries, especially those that are working towards explicit benefits packages, is what sorts of things are in and what sort of things are out or benefits packages. So should they prioritize heart failure treatment and cardiac transplant, or should they prioritize vaccinations for kids? These sorts of things are really the trade-offs that a lot of countries face. And so this is really where we and the Disease Control Priorities Project step in. So Disease Control Priorities has a long history that starts with the World Development Report in 1993, which was a publication by the World Bank focused on health. And this was a very influential report that sought to popularize the use of cost effectiveness analysis and essential packages in low and middle income countries. It was very influential. It was arguably the reason that the Gates Foundation got interested in health, for example. In this report coined the use of the disability adjusted life year, or DALY, as a measure of population health. So it's a very influential document. This work was updated with additional recommendations in 2006, what we call DCP2, and then in 2015 to 18, what we call DCP3. So it went from one book in 1993 to 9 books in 2015, with over 500 authors, 230 peer reviewers, 33 editors, and 172 chapters across those 9 books. And here's a picture of the 9 books of DCP3. And you can see they cover most of the major health topics, including a lot of things that are not thought of typically as global health issues. So we think about infectious diseases and maternal and child health as being the big problems in low-income countries, but we had a whole volume on surgery, whole volume on mental health care, volume on school health and adolescent health and development. So we tried to be comprehensive and to think really outside of the narrow mindset of development assistance and towards all the health needs that countries face. This work is, of course, online and open access. It's financed by the World Bank and the Gates Foundation. And so you can get this on the website, as well as in the World Bank's open knowledge repository, if you're interested. So one of the main innovations in DCP3 was the idea of essential packages, which are basically lists of recommended interventions for countries. And these interventions sort of fall into 21 specific lists that are we organized around health topics or professional communities. So for example, there was a maternal health package and a cardiovascular disease package, and so on in DCP3. And those packages seek to identify all the interventions that fill these 3 basic criteria. 1, they provide really good value for money, cost effective. 2, they're feasible to implement in low and middle income countries. And 3, they address a significant disease burden. And these recommendations came from that list of 500 experts who and peer reviewers who were really thoughtful about synthesizing all the available evidence. And so the evidence that they had was to draw on systematic reviews of cost and cost effectiveness studies, burden of disease data, clinical and implementation trials, and so on and so forth. And the experts and editors then synthesized this together into concrete recommendations around best practices in health for their particular disease area. What we did at the end of the Disease Control Priorities Project was to pull all this disease-specific thinking into the wrapper, as it were, of universal health coverage with this concept of essential UHC. Because a lot of people think about UHC as providing everything for everybody for free right now, and that's obviously not feasible for most countries. And so how can countries get started on the path to UHC with limited resources? And so essential UHC is a subset of all the things you could offer, but things that are relevant in low and lower middle income countries. And so what we did is to compile all the interventions from across DCP3 into one place, to do some harmonization and deduplication of content, to identify what sort of platform of healthcare delivery each intervention would be organized on. And so here we have population-based health interventions, community-based interventions, those that are based in health centers or outpatient clinics, first-level hospitals, and referral and specialty hospitals. And what you see here is the vast majority of the content in DCP3 is focused at the primary healthcare level, broadly construed to be health centers, community care, and first-level hospitals. And so we went from about 350 unique different interventions throughout those volumes to 218 unique interventions, which we called a Model Essential Universal Health Coverage Benefits Package, or EUHC for short. And so this just shows a screenshot of a few of the interventions within the health center platform or cluster of about 60 or 70 interventions. It's just a few things. You can see it's everything from HIV treatment to mental health to reproductive health, and so on and so forth. And the idea is that by pulling all these interventions together, publicly financing a package like this would maximize the amount of health you get per dollar spent. And if you're providing it free, would significantly reduce financial risks for the most needed health services. Now, this is obviously a starting point for countries, not a prescription. So we're not saying every country has to do all these things. This is up to countries to decide. But the idea is that this provides a list that countries can deliberate on, similar to WHO's Model Essential Medicines list. They can adapt it to their context, get rid of things they don't like, add things they do. But it simplifies the evidence synthesis process by having global experts do a lot of the the hard work of evidence review that technical groups and ministries would like to do, but often do not have the time and resources to do. Good news is that DCP3 has had a lot of uptake globally and a lot of impact. And so there's been a number of countries that have had efforts to translate DCP3 recommendations into policy. So you see a list of 6 countries here that have integrated DCP into benefits packages or recommendations into benefits packages and sort of official policy processes. There's a number of other countries that have taken parts of DCP and applied to specific subsets of things. So for example, there's been disease-specific applications around, for example, essential surgical care in sub-Saharan African countries, some work that I've done on non-communicable diseases in Southeast Asia. And so uptake has been, for specific content areas, very enthusiastic. DCP3 has also been really influential in other groups. And so the WHO has developed this compendium of interventions for UHC that I'll talk about later. And DCP3 has been a way of helping think through that. Also, it's influenced other groups that, including the Lancet Commission on Investing in Health, and directions for priorities in health. So I would say it's been generally fairly impactful, but it's gotten a lot of feedback in the past 5 years from partners, from evaluators who say, number one, future iterations of disease control priorities really need to focus more on capacity strengthening within countries. There was a bit of this work in DCP3, building a health economics core within the Eastern Mediterranean region of WHO, but really other parts of the world are less resourced. And so future efforts to help train technical experts within countries and regions to do this sort of analysis is the priority. And the second area of focus is the need for scientific innovation. So new modeling tools, standardization of methods for example, costing benefits packages and other things. And so there's a scientific agenda here as well as a education agenda that is critical as well in a complement to the policy reform agenda that has been covered in the points above. So I'll talk a little bit about number 2 here today and where we're headed with this. I won't talk much about our future thinking on capacity strengthening right now, but that's also been a major consideration as we think about plans for the future. So we're working now on the 4th edition of disease control priorities, which will be a little bit less ambitious than DCP3, but hopefully more research and product and innovation oriented, and reflecting on the lessons we've learned from translating recommendations into practice in countries. And so the first volume is really kind of reflecting on experiences from those 6 countries I showed in the last slide, as well as others. What have we learned and what can we say about what is the need for people working in UHC reforms? What kind of technical analysis do they need? How useful are these academic recommendations? The second volume is on global threats to health, mostly pandemic preparedness and response, but also climate change and other sort of transnational threats. And as you can see, the first and second volumes are underway and will be hopefully released towards the end of this year or early next year. The third volume and fourth volume are more of an update of DCP3 in the areas of intervention and policy recommendations. The third volume is focused exclusively outside the health sector at interventions that improve health but are not implemented by health ministries. So things like tobacco taxes, road safety measures, water and sanitation, and so on. And the fourth volume is really an update of the universal health coverage and health sector and clinical medical content from DCP3. And as you can see, volume 3 and 4 plan to be staggered out over the next several years. This timeline will probably extend further as we get more and more resources to extend the analytics for volume 3 and volume 4 over time. And again, part of that, we want to build capacity within regions and countries too. And so doing this content update in parallel with country and regional hubs of expertise. But what I want to talk about today with regards to digital twins is this thing called the Fair Choices DCP Analytics tool, which is really a modeling tool for designing health benefits packages. So as it currently stands, we're working on over 400 interventions and their applications in over 82 low and lower middle income countries. And the idea here is to have some sort of dynamic online tool for deliberating on what sort of interventions are cost effective and relevant and prioritized in different settings, focusing on measures like cost effectiveness, equity, financial risk protection. How much can each intervention achieve those goals of the universal health coverage agenda? We're working a lot with WHO to align and standardize our definition of what sorts of interventions occur and are relevant within health systems. And so this piece of work by the WHO has been really kind of mapping all the activities of the health system to some sort of standardized taxonomy. So you can see it's sort of grouped hierarchically into various disease areas and subgroups, and then like clusters of interventions. And the idea is this maps to basically nearly all of what healthcare systems do, with specific actions and procedures and interventions being things that are targets of focus for health technology assessment or cost effectiveness analysis. And so we want to pull more and more interventions into the modeling tool from this hierarchy and attach analytics to them. So what can we say about the cost effectiveness of treating gastric cancer in different countries? What sorts of interventions for gastric cancer are reasonable to incorporate? Should gastric cancer even be a priority based on its disease burden, cost of treatment, and so on? Particularly medical approaches. You could always say, let's prevent gastric cancer through diet and alcohol reduction, right? But on the medical side, what technologies can be reasonably afforded in countries and guaranteed free for all? So this structure is meant to, over time, expand the list of interventions and the type of data we have access to begin to develop this tool for deliberating and looking at the cost effectiveness of. At the end of the day, we're aiming for over 7,000 interventions, which will be quite a lot. But it's ambitious, but hopefully with time, we will get there. The way we're thinking about modeling populations, and this is really where we get to the analogy to digital twins, is to look at disease-specific models that are all integrated within one overarching demographic framework, where you could think about risk factors for various diseases that influence the incidence, prevalence, mortality from various diseases, and that those diseases are all constrained within an all-cause mortality envelope, but that over time you could model the impact of, for example, reducing risk factors or reducing outcomes or case fatality from diseases through different interventions. And so different interventions could work at different parts of this pathway. And then, of course, if you act to prevent some diseases now, you also prevent costs for those diseases later. Some diseases or interventions you provide now also reduce or increase demand for others later. So, for example, if you increase access to contraception now, you have to pay more for cardiovascular disease care later because of population aging. So some of those dynamics would be captured in this modeling in a way that helps structure the cost and consequences of specific policy choices for decision makers. Another thing we really want to do is to look at equity and financial protection as concrete goals. And so when we look at, for example, utilization of healthcare in these sort of simulated populations, we would factor in the out-of-pocket cost that individuals face under current financing regimes, how much that would lead to catastrophic spending or impoverishment, and then what impact greater public finance, greater coverage of interventions in UH systems might have on reducing out-of-pocket cost and reducing catastrophic health spending, alongside reducing mortality and serious disability. And of course, from an equity standpoint, you could think about looking at different population subgroups and doing this sort of analysis by population subgroup. So this is obviously a simplification of what more complex disease models might look like, but this shows basically that you can have different interventions and multiple interventions working on multiple parts of a disease pathway in a dynamic way. And getting this all right conceptually has been a major focus of our work to date so far, and we continue to work on improving that because it gets infinitely more complex the more diseases and interventions you add, as you can imagine. This is just a shot of like what the current version of the Fair Choices tool looks like and how it brings in sort of raw data that are then cleaned, and as well as like health outcomes and demographic data, intervention cost and effectiveness data within a sort of one unified model for impact as well as cost that then present sort of league tables of cost effectiveness ratios for interventions and other sorts of things. And of course, there's a sort of user interface or app that we're developing to be able to do that. I won't show you the version of the app that's online now. It's kind of a beta version. It's a little buggy, but what we're hoping to release by June would be a good version that people can use and play with and have fun with, as well as to use in policy processes. And the idea is that this work will be continually updated with new releases, say once a year over the next several years, with improvements to modeling, improvements to data, expanded list of interventions. So over time, the thing grows and grows as resources and time permit. So this is just a picture of what the kind of user interface might look like. This is just a mock-up from a simple NCD test case where you can kind of use the bar to the left where you kind of select kind of from top to bottom some various parts of things. So if you, for example, want to select some interventions and then kind of change numbers on the assumed impact of interventions on particular diseases, you could do that. You could review the costs that were used for the tool as well. And then, that kind of customization that allows you to kind of create your own custom estimates of cost effectiveness, where, maybe the results are presented as a traffic light system where the green stuff is it's definitely a go for every country. The stuff that's in yellow, it's probably a good choice, but there's maybe some nuances, maybe equity considerations or financial protection considerations would sway you to include that intervention in a package in one country, but not in another. And the stuff in red would be stuff that countries probably should not be publicly financing. And again, this is a tool for country level deliberation. So the greens and yellows and reds change, and of course they would change if you edit the inputs as well. So this is a way for people to dynamically deliberate and update as they accumulate local data on particular interventions and their characteristics. And then you could think about summary outputs like, if you choose a package of interventions, what impact would that have on things like all-cause mortality, cause-specific mortality, disability, how much would it cost, that sort of thing. So this is just a mock-up of the kind of user interface that we're working on. Now, I'll talk for the last few minutes about the frontier, where the field, I think, of health benefits packages and policy analysis is headed. And what I'll say here is that there's not many people working in this area, surprisingly. There are people who work in particular disease areas like HIV or other areas where there's a lot of work done with really cool models, but nobody's kind of pulling it together into one overall look at the health system. So various disease-specific constituencies have their own approaches, but there's really not that many people in the world working on an integrated approach to all of health, all diseases, all potential policy reforms, all at the same time. And so that's really where a lot of our work is focusing on, is integrating these things in some very conceptually consistent way. What we want to do in the future is to take advances in disease-specific modeling and other computational approaches and apply those to this sort of analysis. So these are three areas that I think we really want to look at in the coming years. The first is subnational analysis. I'll talk about that in a minute. The second is around routine data that can be used to continuously update estimates. And the third is this concept of robust decision-making. When it comes to subnational estimates, of course, for countries that are decentralized, this is critical because if you just have a national estimate for a given country, that's not very meaningful to provincial or state, health officials who are responsible for designing packages, right? So this is an example of some work we're doing on breast cancer in Colombia as an example of the kind of nice subnational analysis you could do, where you could see that for the country as a whole, you would have the kind of average amount of money or total amount of money and number of lives saved over a given time period, and a kind of like summary measure of cost effectiveness. But you see heterogeneity within regions of a country as well, where the actual cost of doing stuff is low in some areas and high in others because of these characteristics. So on the right here, what you see is that the number of deaths averted from breast cancer screening and treatment is highest in the central part of the country where all the people live. But if you look at the relative reduction in mortality versus the baseline, the biggest impacts on mortality are in the areas that have the lowest current coverage of breast cancer screening. So the poorest parts of the country in the north and the south. And so by thinking about how to target and allocate resources, you can have both equity and overall health objectives in mind and balance those two things. Of course, it's always more expensive to, take care of remote populations because, of distributional issues, travel issues, and other sorts of things. But this gives policymakers a better sense for like how to better tailor and target resources to the local level. The second thing I want to talk about very briefly is the idea of real world data or routine data. And so if you think about policy relevant data out there, or data that can be used for designing policies, real world data would be defined as anything that's not systematically collected for the purpose of science, but that is available for use scientifically. So for example, supply chain distribution information, insurance claims databases. In Africa, you have the DHIS2, which is a big, kind of platform for managing health information systems. So these sorts of data sets are proliferating all over the world in many countries, but they're not really being used for policy that much. And of course, a subset of this would be like big data, which would be like cell phone stuff and internet use and whatever. Big data is not real world data. Obviously, there's a subset of this that's you might think of as big data. But what I'm trying to say here is that not everything about real world data is a big data issue. Some of real world data is kind of small data, but it's all stuff that's not collected for the purpose of science, but is useful. And so health technology assessment today, cost effectiveness analysis today in richer countries mostly focuses on somebody going and collecting data through a scientific process and doing some modeling. with a little bit of an increasing interest in use of real world data. For example, in the UK, there's been some desires to do this for cancer drug approvals. In low and low middle income countries, though, the poorer parts of the world, very, very disconnected from these data systems where most people do these sort of standalone costing studies. They use models from other parts of the world. There's a lot of extrapolation and judgment happening. The idea would be in the future to kind of pull or marry these two things so that health technology assessment and cost effectiveness analysis and benefit package design would make a lot better use of these available data. Now, not all data, real world data, would be available for doing a cost effective. That's more relevant, but the idea would be to take advantage of these data sources, which are more continuously updated and available. So for example, you could track the implementation of a particular policy around free care by looking at reports of out-of-pocket spending through surveys or through administrator data. You could use estimates of vaccine coverage by district or municipality to do more targeted assessments of the cost of scaling up those things over time. And then, of course, 6 months down the road, you can query that data set again and say, how are we doing? What is the new kind of estimate of cost for the future? And so it allows for this more dynamic and real-time, semi-real-time approach to policy analysis that many countries are not set up to do now, but need to be. So I think this is a really exciting area for those of us who work in benefits packages, because UHC is meant to be the goal, right, for all countries. And countries are meant to be covering their populations with needed interventions, and yet there's a lack of accountability and a lack of data on progress and monitoring and evaluation of these sorts of reforms that using real world data could really enhance, of course, delivery of services and patient outcomes. The third thing I'll say is there are some really computationally and theoretically interesting areas to look at around what you might call robust decision making, which is the idea of leaning into uncertainty, not statistical uncertainty per se, but the fact that there's a multiplicity of scenarios by which combinations of interventions might have nonlinear effects on each other. Future events like health shocks or economic growth trajectories in countries might also influence things. And so if you think about a sort of high dimensional space of a bunch of disease specific parameters and combinations of interventions, robust decision making is basically saying, okay, if you're interested in, artemisinin and combination therapy for malaria, what will be the cost and impact of scaling up this particular intervention under a range of different scenarios, not just reflecting uncertainty for that intervention, but also reflecting demographic change, economic change, other types of interventions that might or might not come into the mix for that country, and so on and so forth. And so you could do a lot of modeling scenarios to discover the conditions under which ACT therapy for malaria would be cost effective. And so you could think about sort of dimension reduction approaches to kind of summarize the relative merits of different interventions so that you're making a decision that essentially hedges the uncertainty against the uncertainty you have in the world. For example, we saw with the COVID pandemic how much cancer screening fell off. You could build something like that into a scenario sort of analysis so that if you're wanting to invest in cancer screening in a country, you factor in the fact that you may have disruptions like this from time to time, or that new cures might come along, or that you may have increases in cancer because of worsening risk factors. And so this idea around computational approaches to simulating large numbers of scenarios to help decision makers make more robust decisions and choose interventions that are more consistently cost effective across a wide range of conditions, really, I think, is an advance in the field that allows countries to make more informed decisions dealing with the fundamental chaotic nature of our world. So I'll just summarize with a few key points here. As I've said a little bit, a couple of times, I think it's really clear that low and lower middle income countries in particular need better analytical tools to help set priorities for UHC and health in general that leverage modern data sources or data that are routinely available. Talked a little bit about the Disease Control Priorities Network, which is really the world's leading network in evidence synthesis for health policy in low and middle income countries. And the DCP project is developing this thing called the Fair Choices tool, which is meant to be driven by the needs and interests of low and middle income country partners with a real focus on capacity building, and that this tool over time would be used by more and more countries in their own deliberations. And that I think there's some exciting areas, scientific areas for improvements through, for example, integrating micro level data or real-time analysis of policy, and then thinking about more robust approaches to decision making. So thanks again for having me. I'll take my slides down for now. I'm happy to answer questions.
David, thank you so much for your presentation and informing us regarding the fair choices. There are several questions in the chat. Since we have a small group, I would like to invite each of the participants to unmute yourself and then ask the question directly. So Dr. Young, would you like to go first? You have two questions.
Yeah, thank you, Dr. Watkins. Very insightful for our group, in fact, to understand the global health issues and how the economic and interventions come into play. So when you do the modeling, there are obviously two fundamental problems from what we understand. The heterogeneity, for example, when you look at the economic impact, how the different regions and different countries were considered when you look at the cost for doing the intervention globally. Another question is that how the individual person is being countered towards the global either contagious or non-contagious disease, how that is being transmitted and how that causes a global health issue.
Yeah, it's a great question. So where we are right now is that we're relying very heavily on our friends at the Institute for Health Metrics and Evaluation and the way they've structured estimates of disease burden, mostly at the national level, including at the subnational level for some large countries. So we take what we have available at that level of analysis, which is usually national, in some cases subnational, but only at the first subnational unit, okay? And that's the sort of data we have as the default in the model, and that those can be aggregated up. So if you wanted to look at a report in East Asia, you could aggregate it up, all the countries if you want. But this is really meant mostly to be a tool for country level and subnational decision making. And so we try to feed those country specific data in. Some users, obviously, if we want to aggregate data and produce reports for regions or the world, as we do, can do that, but it's really country by country. And so you just sort of loop over countries if you want to do multiple. The direction for the future, though, is, as I said, to kind of split apart countries more and more into subnational units, and so that local decision makers have access, who have the authority to make decisions around benefits packages and disease programs, have the ability to do that analysis with their own local demography and epidemiology in mind. And so as those data become more available, we have the ability to split the population into different groups. What we don't have yet, but which is another area of innovation, is the sort of geospatial dimension. So for outbreaks and contagious diseases, as you said, that kind of modeling of transnational benefits also needs some sort of spatial temporal kind of considerations. And so bringing that way of thinking about modeling in will be the next step. We need to get the locations right first and get the data right. But once you have a real good sense about the evidence base for interventions, then interventions for controlling outbreaks and whatnot become a little easier to model, looking at the interdependency across borders. That's probably 2 or 3 years down the road, I think. But yeah, it's an area we definitely want to do.
Great, thank you.
Thanks. Ben Levis, would you like to unmute and ask the question?
Yes, thank you. Fascinating. So it seems, if I understand it correctly, you guys have sort of done a really core part of the heavy lifting, which is gathering the expertise of of a lot of medical professionals and getting kind of general agreement on core is the word, interventions that are sort of most bang for the buck, generally speaking. But of course, one can imagine an almost infinite number of sort of less medically specific, but nevertheless very important for health outcomes. All kinds of other things like diet or recommending diet, or public relations initiatives you could imagine to help get people to think about certain lifestyle things differently. All of which are going to be heavily, will have sort of, they'll be, have cultural dimensions, in the sense that within a country or between countries, the extent to which those kinds of initiatives could vary, would be effective, could vary a lot. And I suppose cultural for all kinds of cultural reasons, you're going to have differences in terms of what your core pieces, how those are going to work as well. So my question is, sorry, it's a little long-winded. It occurs to me that a feedback mechanism that as these programs start to get implemented by countries and they start to tweak them for their own purposes and then monitor them, there could be a lot of interesting new ideas that you'd want to capture and get fed back into the core set of things to consider when you're setting up a health policy. Does that make sense?
Yeah, it does. And I think I'll point to, I'll make probably 3 or 4 related points in response. So one of the major conceptual pieces of work that we've done over the past several years is to really define a consistent approach to what is an intervention, because it turns out that everybody defines this in a different way. And so we have thought a lot about theoretically what this means. And so there's a few different ways we've thought about this. Number one is that there's sort of boundaries of what the health system actually does. And so, for example, you could think about interventions or things that are done that directly influence health and are delivered by healthcare workers and reimbursed by insurance systems. That's one kind of thing. There's also a separate set of things that you might call public health functions, which are things that are done by public health departments, but that are not person-to-person services, but like mass media campaigns, behavior change interventions, in some cases, things like vaccination outreach, that's personal services, but not done by, doctors and nurses in a building. And so figuring out kind of where, and of course, there's things that happen outside the health sector, like, road safety and things like that. And so consistently thinking about where the boundaries of all these sort of interventions lie and how they relate to each other and from a causal standpoint along that sort of like chain that relates to better health outcomes. That sort of mapping of interventions across that causal chain has been a really kind of big conceptual piece of work we've been undertaking. The other thing is that there are a lot of things that influence health indirectly. And so a lot of what we think about as interventions like digital health stuff, it's not an intervention, it's really more of an implementation strategy. And so people are like, let's talk about mHealth for TB. Is that an intervention or is that just something you do to enhance uptake of TB treatment, right? And so we've had to wrestle with like, what exactly is an intervention for the purpose of reimbursable health services? And what are things that public health authorities might do to enhance the uptake of those things? Because if you just start screening for diabetes and you don't have access to diabetes treatment, you're not really improving outcomes, right? And so screening doesn't happen in isolation from treatment. And so you don't talk about the cost effectiveness of screening except with reference to a treatment regime. And so these sorts of conceptual interdependencies across various health system activities, it's a lot of work actually, and there's not a lot of people trying to figure this out. And so that's been a big innovation. A big part of our partnership with WHO is thinking through how to consistently allocate causality across the health system to make these sort of claims about the impact of potential changes. The other thing I think that's important is that you're absolutely right that culture and local context matters. And we've also learned from trying to produce generic recommendations that, there's no one size fits all, and like no package of interventions is right for any one country. And so there's this sort of process, especially within the user interface we're developing, of allowing for a degree of contextualization. Some interventions just aren't relevant because there's no malaria in a country. Some interventions, like the names of them really matter to some policymakers, like how you describe it, or the way that they're defined locally with regards to treatment guidelines differs. And so that contextualization is also a piece that we're really trying to take seriously in partnership with countries to say, how can we provide a more flexible tool that adapts to local context, whether it be culture or health system characteristics, and so on and so forth. And so it's a lot of hard work, I'll put it that way, but it's something that we have constantly gotten feedback on, is that if you produce a public good, it has to be relevant and applicable and flexible. And that's a pretty heavy lift.
Great.
But it's fun.
Wonderful. It just occurred to me too, all of that whole world of so-called alternative medicines, which vary from country to country, they'll have their local kind of cures or traditional local approaches would also be good to capture and track in this sort of thing, right? Thank you.
That's absolutely right. But some countries actually, offer those services for free through public systems. Sometimes they don't. It kind of depends on the country. But certainly there's the boundary between allopathic Western medicine and traditional medicine is not sharp, and I think in many cases very reasonable to publicly finance complementary and alternative services if they have evidence for impact. So this is an important area, and I think as we expand the intervention list, that we seriously take a look at things that have some semblance of scientific evidence and or cultural relevance. That's the sort of universe of things we'll consider.
Thank you. Thank you very much.
Yeah, Dr. Joaquin, I think
Great.
this is a.
Go ahead, Shane.
Sure. I just want to make quick comments from a more from an industry perspective. I think this is awesome work. It's pretty ambitious goal to kind of model the whole entire health system. You know, by working with government officials, currently actually I'm working with NIH. Right? The U.S. government also thinking a similar issues, right? How do you allocate the limited resources? How do you improve healthcare will reduce costs? And, you know, some of the question there is how we allocate dollars to have the biggest impact. You know, how to identify the disease with, you know, the biggest burden, right? So I want to just ask you, Dr. Joaquin, you know, how do you, you know, leverage data to kind of inform this kind of decision, right? I think the model is a good attempt to do that. The model, the digital twin is good as some of the input data that may be incorporated to make those kind of decisions. So love to get your thoughts in terms of, you know, the data that you may rely on to get into this model and to inform the policy making. And how do you see, you know, some of the AI, you know, maybe even AI generated data to assist to improve, continue to improve your digital twin here?
Yeah, great question. So our focus to date has been on providing guidance for countries where health-related data are so scarce that anything is sort of better than nothing. Not meaning that from a quality standpoint that we sacrifice quality, but that we recognize the limitations of data. So what the tools that's currently been designed is really around kind of producing starting points for estimates for larger population groups for countries that are otherwise going to make decisions on a very ad hoc basis. And countries that do not have currently the kind of data policy cycle. Dr. Sue is making me echo. That don't have this sort of data generation and policy kind of integration, right? So that's sort of where we're headed, is to create that kind of structure. That being said, the way that we're thinking about interventions, the list of interventions, the data we have on efficacy and whatnot of interventions is very relevant in the US and other higher income countries. And one potential spinoff of this, which I'm quite happy to talk with you and any of your friends in the industry about, would be a version of this that really takes it, that looks at the level of analysis for a large insurer in the US. Because that's really where the decision making happens, right? I mean, the U.S. government is pretty toothless. So I mean, there's a sort of moratorium on cost effectiveness thanks to Obamacare, but I mean, insurance companies still use this information. So they are the natural audience in the U.S. and in other countries that have social health insurance systems too, right? And so if you think about working with large insurers who have claims data, where you can actually do more kind of thoughtful micro simulations of large numbers of people, that's more kind of the digital twin kind of direction that you could go in a data rich environment like the US. And so you can imagine a sort of divergent but related set of tools that built off of this basic infrastructure that's really focused at the payer level and leverages individual level data from payers. Obviously, there's a lot of issues there around how do you kind of mine through routine data for indicators that are meaningful. AI could help there too. There's a whole research agenda, I think, there that this stuff could get into. It's not where we've headed so far, but happy to talk more about that too. And certainly, there are a lot of issues with access to healthcare and suboptimal health outcomes in the U.S. that, you know, I think could be addressed through this. Now, one very concrete starting point for this is insurance drug formularies.
Yep.
You know, because you can play with prices of drugs within interventions very easily and say, oh, well, you're paying way too much for drug X, drop that, replace it with drug Y. So there's maybe some low-hanging fruit within the US healthcare industry and market where you could say, let's use these tools for performing various more tractable parts of the policy process. And then later on, you could look at equity and all this other sorts of stuff too. But yeah.
Another related question is how you might tracking or measure the outcome of this efforts and then potentially feedback to your system to improve continue to improve. Any thoughts there?
Yeah, I mean, I think from a software standpoint, there's one thing, but I think from a policy process standpoint, we've been working on monitoring and evaluation frameworks for benefits package design and for use of these tools. And so as we're testing out the tool prospectively in some countries, looking at how it's influenced processes. And then of course, when policy change happens, how do you monitor and evaluate that as a separate thing altogether? But we are very keen to demonstrate that this sort of stuff actually makes a difference to patients. And we think it does. And certainly in a lot of countries, a lot of money is being moved around in response to these data. So we're very mindful of the need to try to track that and demonstrate effects and mitigate harms.
Wonderful. To discussants, so Dr. Shen Liu will be representing the industry side, and Dr. Ling Chao, and she will represent the perspective of trainee. So hopefully we are going to have the discussion for 10 minutes-ish, and we are going to open it up for the questions from our audience in the last 5 minutes.
Yeah, in the observation of time, so I just make a quick introduction, and then I maybe ask a couple questions to you. I think this is a very interesting topic, right? We have a keynote speaker talk about public health. Now we have a precision, health using this digital twin here. So it's a pretty interesting topic, I have to say. So at Booz Allen, we basically help the government transform their operations, advance, scientific research, innovation. We have been helping the federal government, especially in defense and health practice, to bring today's most cutting-edge technology to prepare for the future. Currently, I'm working at the NIH, and the CDC accounts to help our client to make better decisions and bring some of the cutting-edge AI and the digital solution to our government. So yesterday, I was telling you, we have a meeting with NCI, National Cancer Institute, a full day of AI Innovation Day. Essentially, we talk about a lot of AI-related topics, like AI-related data, responsible AI, AI-ready workforce, generative AI, and some other AI topics. The digital twin does come up during that conversation. It's there's a lot of interest in AI and the digital transformation that we're talking about here today. So it's very insightful models and research. One question I have, Dr. Shumovich, is you talk about different models, right? Various different models, and then how do you see those models can be like applied to a different disease, or is every single disease will have its own models or different type of models? How can we basically manage that, right? So basically this research, how you can apply different type of disease, and so that way we have a digital twin that can be implemented or in a way that can deployed to help drive decision making. So maybe this question is a bit to the future, right? We talk about real world application of the models, but I'm just wondering how you can scale this to some other disease areas, and also how do you determine those the best model, or the model can apply to the other type of disease. We just wondering, like, do we need every single model, or every disease have a different type of models, or and even every patient you have a different model? Just hopefully you can share some insights there.
Thank you for your question. Yes, every disease will have its own model. I think certain components can be reused, and certainly the infrastructure for data assimilation, model building, and model simulation, visualization of model predictions could be reused. And I'm talking about infrastructure. However, the actual mechanistic models have to be disease specific at a certain level. So a model for leukemia is going to be very different from a model for glioblastoma, which is a type of brain cancer. It's not the same disease. It's not the same tissue type, not the same cell types that are involved in the disease. It's not the same type of data that you get. For example, in
for the same disease or even the different phase of the disease, do you need different models as well?
yes, even for the same disease, you typically would use multiple models. A good analogy is in weather forecasting. They never use one model. The forecast is never based on one model. It's usually an ensemble approach of multiple models, and that's how actually the panel on digital twins that I mentioned from the national academies also envisions it. That the predictions must be made with the help of multiple models, and then the predictions have to be integrated. And as I mentioned, uncertainty quantification is very important. So the predictions they have to come with uncertainty quantification, just like when you see a hurricane trajectory in the weather channel, and they are predicting where the hurricane is going to go. They always show you the confidence intervals, if you like. That's very important for decision making. So I think I answered your question about whether multiple models and how to scale this. It will have to be disease specific. However, it's also important to recognize that all of the organ systems are interlinked. When a patient receives a chemotherapy, for example, it affects the patient's liver and kidneys and the heart. And so we are going to need modules for these other organ systems in order to make integrated predictions, ultimately leading to a whole human virtual twin or digital twin. This is still obviously in the future, and we have to start with something with a narrower scope, starting with a particular disease or multiple diseases. My own work has also focused on digital twins for pancreatic ductal adenocarcinoma, on metastatic melanoma, as well as now glioblastoma. I mentioned the brain cancer, and the modalities are very different. So for example, for glioblastoma, you would use MRI data. For acute myeloid leukemia, you don't use MRI data. You use other kinds of data. So that also dictates the types of models that one can use.
Very helpful. Thank you.
Wonderful. Lane, do you have any question?
Yeah, I want to actually add two discussion points from a methodological perspective. Like Dr. Shmulevis, pardon me if I don't pronounce your name right.
Okay.
I think the great advantage is digital twin is not a single model. It's a whole system of models to provide a unified picture of the patients. I think an advantage over traditional machine learning or clinical is ability to integrate domain knowledge with the data-driven model. Like you mentioned, the mechanistic model. I think we know that they contain knowledge from clinical trials or large-scale experiments. It can be seen as a type of domain knowledge. But when we apply this to a particular patient, they can lack personalization because they are not as flexible to incorporate all the measurements or nuances in one specific patient's data. But on the other hand, we have machine learning. They are more flexible. You can give it as much data as you want, as many parameters, and you can dig into the massive data to find the patient-specific patterns or specific characteristics. And digital twin can be great to leverage both worlds. And I think you provided a great example of a complex system with mechanistic models, knowledge graph, machine learning, all displayed in a dashboard. Yeah, so I think this is more like a comment on this. I think the design challenge is how to coordinate all these different information from multiple sources, different models. Yeah. So yeah, this is more a comment. Another point I want to discuss and also get your thought on is the typical limited data problem in healthcare. So like in an ideal world, we want to build a digital twin that can gather all data from a patient. Like 24/7, we collect temperature, blood pressure, imaging, genetic data, anything we want. Like but data, that's not feasible because one is the cost, but the other one is the real-time synchronization between the virtual and the physical patient. Like there's computational challenge there.
That's a good question. I want to add to that as well, right? I mean, how do we integrate, multimodal data or even omics data together to support this kind of modeling or digital twin, right? That's a very real challenge we are facing here. So we also like trying to figure out how we can help our client at NCI to combine their very diverse data sources, different researchers from different sources. It's a big challenge. I want to get your thoughts.
Yeah, thank you for your comment, first of all. And you're right that it's not feasible to generate continuous data in many cases. In the case of a disease, the data are usually generated when a patient comes into the clinic. And indeed, the data are multimodal, multi-omic data. They could be genomic. In our case, it's flow cytometry. It's also treatment response data from like peripheral blood, complete blood counts with differential, and so on. So there is really no need to integrate for the sake of integrating. You need to use the data in order to build the models, to calibrate the models, and to make the actionable predictions. So that process is called data assimilation. And that's the key process. How do we get the data with its uncertainty that is quantified, and then calibrate our models in such a way that we make the best possible predictions? And that ultimately becomes a computational problem, with an optimization problem, if you like, where you have to do parameter identifiability, parameter sensitivity, all sorts of analysis in order to define what kind of parameters are the most important ones to calibrate, and can we do it with the type of data that we're getting. There's a really good example of a digital twin is a continuous glucose monitor with an artificial pancreas. And that measures glucose continuously, 24/7. And there is a control feedback system that releases insulin based on a personalized, calibrated model for that patient. So that's an excellent example of a digital twin. For some diseases like brain cancer, you would not be able to get 24/7 measurements. So nonetheless, the digital twin requires that there are measurements over time, and the models are recalibrated based on these measurements. That's what makes it a digital twin. That is not just a static model, and we're not just integrating data for the sake of integrating data. I hope I answered both of your questions.
Yes, you
That's
did.
really wonderful.
We need a 5G and, edge computing and, virtual reality all come to true before we can implement this. All right. Over to you, Dr. Su.
Yeah, and it's very exciting that Ilya, your team also published a paper regarding a digital twin for type 2 diabetes. So we are very keen on hearing more about the most recent research from you and your team. Thank you so much for your presentation today. And we also want to use the opportunity to express our appreciation of the keynote speakers, discussants, as well as the audience who participated in the webinar by sending your questions in the chat. So Joy, since we will have a private session right after this one, and then you can save your question to Ilya by then. For anyone, if you have any particular question but don't get the chance yet, feel free to stay for several minutes, and then we will have a private session to get your question addressed. I would say that I highly appreciate that you joining us on Friday, like late afternoon in the East Coast, and then it's a kind of like missed lunchtime for the West Coast folks. And hopefully you will join us in upcoming conferences. We do have 2 in May in Boston, and hopefully we will be keeping in touch. Thanks, everyone. So officially, we will close this webinar, and then we will also open the floor for the small gathering in the same meeting. And for the panelists, discussants, and other organizers, feel free to stay. And for anyone in the audience, if you have a question for us, and feel free to stay as well. Guanrong, we are so proud of your work.
Do you need me to stay? It wasn't clear to me.
Let me see if there is any question for you, and then so let's check in 1 minute, and then we will know whether that's something beneficial for the audience.
Okay.
Joy, your question related to scalability has been answered. And then there is also the question related to like the patient role. Would you like to ask that question? You are on mute. Oh, you are on mute.
Yeah, Dr. Shmulevich, your presentation highlight the development of digital twins for individual AML patients adapted for predicting disease trajectories and drug responses. Considering the critical role of clinicians in treatment decision-making, how do you envision integrating the insights generated by the AML-DT with clinical expertise in a human-in-the-loop framework to optimize the treatment outcomes and ensure patient-centric care?
Well, I think the short answer is that the decision is always made by the doctor together with the patient. It's a mutual decision. It's never made by a computer algorithm. The role of the digital twin is to produce a prediction, a forecast. That's it. It's not really creating a recommendation. And so I think that gets at your question, that the clinical expertise and knowledge of the clinician is absolutely central, and it is not diminished by the digital twin or the use of the digital twin. It is only another tool to enhance the clinical decision making.
Thank you.
Thank you, Ilya.